Hi, I'm Dr. Stephen Brazis, and I'm here today with two of my colleagues and very good friends, Dr. Locke Johnson and Dr. Michael Phelps. We're here today to discuss some questions pertaining to the oral surgery field of dentistry, which many of my patients have asked over the years. So Locke, if I could, I'd like to ask you, maybe you could pretend I'm a patient of yours, and just take me through the procedures you would do for an informed consent, so I know what I'm getting into with the wisdom tooth extraction and what my expectations might be.
Ultimately, Steve, when it comes to my informed consent, I go more for the expectations, what to expect, primarily to go over at the beginning, and then the possible risks associated with the procedure. And so the expectations I give patients are that the possibility of swelling, some post-operative bleeding, discomfort, and the need to modify their routine to avoid excessive swelling. My primary goal on all my patients is to minimize the amount of post-operative edema / swelling, because that is basically what limits how quickly you bounce back. And therefore, we're really proactive with the use of ice packs after the surgery, making sure patients use a cold diet to avoid using heat, which could potentially aggravate swelling, and in addition to maintaining the elevated head position to minimize swelling. And then we go over the different types of ice packs that they could use post-operatively, being just plain ice, gel packs, or even bags of frozen vegetables, which make great ice packs. And then I go over the actual possible risks of the procedure. And the risks that are the most common would be swelling. That is a potential risk. Excessive amount of swelling can be very uncomfortable. And then the things that potentially can happen with infrequency would be altered nerve sensation or nerve damage from the surgery, which would most likely be temporary, but potentially could be permanent. In addition to the possibility of damage to adjacent structures, and that could be also teeth or crowns, which is very infrequent but can happen. And then also the possibility of a communication with an upper sinus during the removal of an upper third molar. Again, even though this can happen, it's easily managed and there shouldn't be a post-operative problem related to it. Those are the real basic backbones of what we sit down and talk about prior to doing third molar removal for our patients.
Well, considering the sinus exposure, what you say that's very easy to manage typically, what exactly does that entail? How do you manage that?
When you do get a sinus exposure, the key is the size of the defect. If the defect is less than a dime, let's say, it doesn't require anything more than just primary closure so that water and food and debris from the mouth cannot go into the sinus, and does not require a graft of any sort. However, if the size of the communication is greater than a dime, at that stage we usually do some sort of resorbable membrane in the area to prevent a pathway for fluids and debris from the mouth to make their way into the sinus, which would make it very uncomfortable. It's not the end of the world, but if you could avoid it, that'd be the way to treat it. And then the end is just having